Good afternoon, and welcome to today's webinar, Clinical Application of High-Sensitivity Cardiac Troponin Testing in the Emergency Setting. My name is Joyce. I work in the education team at AACC, and I'll be your moderator. We are delighted to bring you this webinar presented by AACC and generously supported by Beckman Coulter China. This program is accredited for 1 Accent Continuing Education credit. I'd like to point out that this webinar and the following question and answer session has been recorded in advance and can be stopped and started at any time. For viewers who would like a transcript of the audio of this presentation in Mandarin Chinese, please know that a link to this resource is provided directly beneath the webinar viewing window. So let's get started. Thank you for joining us today for today's webinar, Clinical Application of High-Sensitivity Cardiac Troponin Testing in the Emergency Setting. Please welcome our presenter, Dr. Peter Kavsak, a professor in the Department of Pathology and Molecular Medicine at McMaster University in Hamilton, Ontario, Canada. He is also a fellow of the Canadian Academy of Clinical Biochemistry and the AACC Academy, the American Association for Clinical Chemistry, and the Canadian Cardiovascular Society. He provides service as a clinical chemist within the Hamilton Regional Laboratory Medicine Program and is primarily based at the Juravinski Hospital and Cancer Center with special clinical and academic focuses and interests in the cardiac and cancer-related laboratory tests. Previously, he was editor-in-chief for Clinical Biochemistry, and he is an editorial board member on 5 different scientific journals, most notably Clinical Chemistry and Clinical Chemistry and Laboratory Medicine. He has over 180 publications with approximately 70% in the cardiac field. He is also currently a second-term member on the IFCC Committee on Clinical Applications of Cardiac Biomarkers. Dr. Kavsak, we are glad to have you present today. You may now begin your presentation.
Well, thank you very much. First of all, I'd like to thank Beckman Coulter and Beckman Coulter China for the opportunity to speak to you today about high sensitivity, as well as the AACC for facilitating this educational event. So we'll get started. So obviously the title of the talk is Clinical Application of High Sensitivity Cardiac Troponin in the Emergency Setting. And let me just say that this has been a focus of mine for over the past dozen years. And so it really is a pleasure to talk to you about some of the stuff we've done in the past, as well as other work and other advances in the field, because the area has tremendously evolved in the past dozen years in regards to cardiac troponin measurements and specifically in regards to high sensitivity cardiac troponin. So the first thing I want to note is I do have disclosures from industry that are listed here. I am also very grateful for industry support that has allowed me to perform various studies over the number of years, as well, not listed on disclosures. And I'm very thankful as well for the public support I've received from granting agencies that has also led to some of the work that I'll be presenting. So the objectives for today's webinar are as follows. The first one is to discuss the analytical attributes of a high sensitivity cardiac troponin assay. The second is to plan quality control testing specific for high sensitivity cardiac troponin testing. And the second one is really something that in the laboratory we should be doing, and I'll present some data as to how laboratories can improve the service in this regard. And the third objective is to kind of review and evaluate the strengths and weaknesses for earlier testing protocols for high sensitivity cardiac troponin in the emergency setting. And this has gained a lot of attention, obviously on the laboratory side, but perhaps more importantly on the clinical side when evaluating patients with potential chest pain. Okay, so where do we begin? The first thing is that I would really recommend everyone to look at the following publication. It was published in an April issue of 2018. It was a joint effort by the AACC Academy and the IFCC Committee on Cardiac Biomarkers, where we provided 10 recommendations on laboratory testing, and specifically with a focus on high sensitivity troponin. So of the 10 recommendations, I just want to focus and perhaps narrow it down to a few of them that are relevant and pertinent for this presentation. The first is on the fourth recommendation is actually on the 99th percentile, so you cannot give a talk with cardiac troponin without obviously highlighting the 99th percentile, and there'll be some discussion on there. And the fifth recommendation from this guideline of this paper is on the classification of cardiac troponin assays. So this will basically, these two recommendations are really going to be the focus for objective one. The first recommendation that was in this document is actually on quality control practices, and specifically with a focus on high sensitivity troponin. Obviously, the second and third follow up on that, and that's really going to be the focus on objective two. And finally, objective three, I think it's important in the laboratory to understand some analytical variables that can impact on clinical interpretation, which was highlighted in our recommendation number 7. And finally, the last recommendation talks about what's actually a change when we think about troponin values, serial measurements. And again, that will also be discussed. So as mentioned, this has been a 12-year plus journey for me, specifically with Beckman Coulter. We published the first analytical characteristics and utility of a high sensitivity troponin assay in clinical chemistry back in 2009. And so what was very interesting in 2009 is that we actually measured samples in 2007 on samples that were collected in mid-90s. And we measured it with the prototype assay. That was in 2007. We kept those samples and we measured those same samples, so 20 years later or so, with the regulatory approved Beckman Coulter assay. And so as you can see on the right side of the slide, you can see at the bottom, you will see Beckman's 2007, that's the prototype assay, that was a research assay, versus on the y-axis, the Beckman 2007 high sensitivity troponin I, the regulatory approved assay. And so what's really remarkable here is that on samples that have been collected over 20 years, measurements by 2 different assays, 10 years apart, we can actually see a remarkable agreement between the concentrations. Now, the slope, the regression analysis would indicate the slopes are a little bit different and so forth. But I really want to stress the fact is that if an assay is designed appropriately, you will be able to monitor and pick up cardiac troponin in samples that have been stored for quite a number of years. So this goes to the stability of the analyte, but importantly, it has to go with the assays and its ability to monitor that. The last thing I want to just highlight the fact is that this is going to be a topic for later as well, is that you can see with the prototype Beckman assay, the research assay in 2007, we had a couple of these huge outliers, which have obviously in the 2007 regulatory approved assay are actually at a lot lower concentrations. And so I just want to plant that seed in your mind is when we think about factors that perhaps affect troponin measurements, why are there differences sometimes between assays? And as you'll be able to see in subsequent slides, that improvements over the past dozen or so years have actually led to a reduction in some of these analytical aspects and perhaps elevations. Okay. So the analytical attributes of a high sensitivity cardiac troponin assay. So there are 2 main aspects of this. First, the percent CV at the 99th percentile should be 10% or lower, and obviously that is an important metric when we talk about precision. And the second is that measurable concentrations should be attainable at a concentration at or above the assay's limit of detection for greater than 50% of healthy individuals. So these 2 criteria are something that the laboratory can provide, obviously should be able to monitor an assay at appropriate precision, and importantly, obviously if you have the resources, you'll be able to perform a reference interval study and to demonstrate that indeed majority of the patients or the healthy individuals are above the 50% above the LOD. So how was it or how is it to monitor a contemporary assay at the 99th percentile? So prior to us switching from a contemporary assay to a high sensitivity assay, we actually manufactured and made a material, quality control material near the 99th percentile, which for this assay was about 0.03. And so you can see that this is our quality control material measurements over the 2 years. And you can see that the type of precision here with a contemporary assay, it's very challenging to meet the criteria. I mean, this type of variation that you see here, the shifts up, the failures, what have you, regarding quality control, this represents the 20% CV at the 99th percentile with a contemporary assay. So this is actually still guideline compliant when you think about contemporary troponin assays, that they allow a CV at 20% at the 90th percentile. But you can see as well that how challenging this was for us to monitor and provide as best as we could reproducible results at the 99th percentile. So this is a contemporary assay. What happens when we switch to a high sensitivity assay? Well, you can see here with a high sensitivity assay at a concentration that is well below the limit of detection. So this is 4 nanograms per liter, or would equivalent be 0.004. And again, most contemporary assays can't measure below 1.01 nanogram per ml or 0.01 microgram per liter. So this represents quality control material that would be undetectable with a contemporary assay. Well, with a high sensitivity assay, not only can we detect these concentrations, but we can achieve precisions at around 4 with fantastic, or reproducibility with fantastic precision, less than 15% at a value that would be well below the 99th percentile. So just by objective metrics, how well we can measure normal concentration, high sensitivity greatly exceeds performance as it compared to the contemporary assay. And this type of performance is also applicable and evident when looking at the 99th percentile. So here we can see, using, again, a quality control material near, this is a patient pool material, near the male 99th percentile, we can actually see that if we look at here the distribution of all the results, again, this is approximately a year of results, close to 2,000 data points. Each of the curves, the Gaussian distribution curves, are different analyzers. And what we can see here is the fact is that there is really no difference between the sites that we were able to demonstrate appropriate precision at the 99th percentile. And really, there is no difference between the analyzers at the different sites. So this goes to the fact is that having a high sensitivity, you are able to achieve a precision below the 99th percentile. And more importantly, you actually are able to demonstrate very close agreement between the different sites as well. And so this would mitigate and help prevent misclassification in patients if they present at one hospital versus another due to this superior performance. So one other thing, obviously, is the fact is we have better precision with the high sensitivity assay, but the other aspect is measurable concentrations. And so one way to think about this is the typical iceberg. With a contemporary assay, where we couldn't measure really normal individuals, what we focused on was the fact is how well we could measure at the 99th percentile. And this is where we tried to achieve a 10% CV, and we could allow up to 20%. And as I demonstrated earlier and showed you, it was very challenging to do that. But that's where we are at the current contemporary assays. We're just focused on how well can we measure at the 99th percentile. Well, with a high sensitivity assay, not only can you measure very well with at the 99th percentile very precisely, more importantly, we're able to actually detect troponin in the vast majority of individuals. And this type of information, obviously coupled to how well we can measure troponin precisely, but the fact is that we can actually detect normal concentrations is really important when we think about earlier diagnostic algorithms and change criteria and able to risk stratify. This can only be done with a high sensitivity assay. And so below here in the slide, you can see 2 publications from 2009, one in New England Journal of Medicine, one in Clinical Chemistry. And The one on New England Journal of Medicine, very important publication by Keller et al. From Stefan Blankenberg's group, looked at the Siemens Ultra assay. It is not a high sensitivity assay. It is a very good assay, but it's not a high sensitivity assay, the Siemens Ultra assay. Siemens does also have now a high sensitivity assay, but at the time in 2009, this was a contemporary assay. And so you can see here, here's the 99th percentile, but realistically, in close to 4,000 individuals that they measured, vast majority of individuals had undetectable concentrations. Now, how does this compare to a high sensitivity assay? Now, here's the prototype version that we worked with Beckman Coulter, and now you can see that if our limit of detection is somewhere around here, we can actually see that there's a nice kind of distribution. We're able to measure troponin in the vast majority of individuals, and it's not quite Gaussian, but normal distribution, but we are somewhat getting a close to normal distribution, or at least measurable concentrations. So this is, again, a very unique attribute of a high sensitivity, is that we'll be able to measure troponin in the vast majority of individuals. So our recommendation for, in the clinical chemistry, the joint effort by the ACC Academy and IFCC Committee, was the fact is use a defined reference population to report the 99th percentile concentration according to sex-specific cutoffs. Obviously, this recommendation is not relevant for contemporary assays. And the reason for that is that, as mentioned previously, contemporary assays are unable to measure troponin in a vast majority of individuals, so you really can't see a difference between males and females. However, with high sensitivity assay, it becomes very apparent in those healthy individuals that there is a difference in concentrations between males and females. And so part of our laboratory recommendations are to obviously report high sensitivity assays per sex-specific 99th percentiles. This has been obviously also endorsed by the fourth universal definition of myocardial infarction in 2018. And as you can see here, the rationale also being that significantly lower values are observed among women compared with men, and therefore sex-specific 99th upper limits of normal are recommended for high sensitivity assays. So biology tells us that there's differences in the healthy state. The issue is that some of the clinical studies that have been performed to date haven't really seen a net clinical benefit. And so this is where there's this also caveat that there is some controversy as to whether this approach provides valuable additional information for all high sensitivity assays. So there's more work in this area that is ongoing, and more data will be coming out to really flesh out the role of sex-specific 99th percentiles with respect to patient outcomes. So how does one perform a quote-unquote 99th percentile reference population, or determination of the 99th percentile in a reference population? This is a very challenging task that the vast majority of laboratories are unable to do. And here's a publication in the March issue 2020 in Clinical Chemistry that looks at the actual universal sample bank from the ACC, and actually nicely describes how the patients were identified, how patients were excluded, how other biochemical parameters were used to also cone or screen out individuals with perhaps some clinical disease. And so what you can see here is that from 850 individuals, but 150 of them are excluded, even though they're healthy and they walk in and they donate blood. But about 150 are excluded due to mostly in the fact is that they actually have some obviously issues in regards to biochemical abnormalities. And so when you actually, this type of process has been documented in the literature, and even though the 2018 recommendations provided some guidance on how do you derive and develop and kind of assess a population to see whether it's normal and if it's healthy enough in order to measure and interpret and derive the limits for 99th percentiles and so forth, there is still a lot of variability in regarding to a patient population. And so this is also illustrated on the right side of this graph, where you see that actually there are different levels, and these are all the different troponin, high sensitivity troponin assays. And the one thing that I just want to highlight the fact is that here's the overall population at the top. But if we just look at the fact is, say, men versus females, one can also see that here's an example of one high sensitivity assay that male concentrations are significantly higher, 99th percentile as compared to females. And this is typically evident for all the high sensitivity troponin assays. So however, it is important to note is that how you define your population and what criteria you use to develop and refine your 99th percentiles, including statistical analyses, will greatly impact on the values that are derived for the upper limit of normal or upper reference limit when assessing the 99th percentile. So to kind of illustrate that point, here is just some ratios that were provided obviously from the guideline recommended healthy population from the ACC Universal Sample Bank, and basically that 99th percentile was divided by the manufacturer 99th percentile. So if there was 100% or agreement between what was derived in the ACC Universal Sample Bank as opposed to manufacturer 99th percentiles, the ratio would be 1. So as you can see, the vast majority of assays, the 99th percentiles are very different from the the ACC, Universal Sample Bank as compared to the manufacturers. So again, this is kind of highlights the importance is that laboratories need to look at the 99th percentile, determine how it was derived, if it's applicable for your population, or if you're deriving a 99th percentile from healthy individuals, that you provide and you perform appropriate statistical analyses to see whether or not it is applicable to your population. And so this is just, again, illustrates that the 99th percentile has been very important and is important to use in order to identify myocardial injury, but there is some variation in regarding to the reporting and clinical use of the 99th percentile. So again, majority of assays or majority of laboratories are unable to determine or to derive a reference upper limit of normal with 99th percentile and to really assess if healthy individuals, both men and women, have concentrations above the limit of detection. And so that was the recommendation 5 in our joint recommendation document, that in order to define a high sensitivity assay, that troponin concentrations at or above the limit of detection, at least 50% of healthy men and women. And if they don't get that, then we would perhaps consider them as contemporary assays. But again, this is very difficult for laboratories in order to obtain large healthy populations to assess measurements. And so one alternative approach that may be of use is the fact is that if for those sites out there that can't perform reference population testing, for determining or perhaps even LOD testing, and we'll talk about that in a little bit. Perhaps one other thing one could do is the fact is actually determine or measure a quality control material below 10 nanograms per liter. So by the vast majority of high sensitivity assays as compared to contemporary assays, as a general rule, most of the contemporary assays have a lower limit of 0.01. And high sensitivity assays, or 0.01 micrograms per liter, which is equivalent to 10 nanograms per liter. So vast majority of conventional assays are unable to measure concentrations below 10 nanograms per liter or below 0.01 micrograms per liter, whereas a high sensitivity assay can. And so there is actually some published criteria regarding allowable bias as well as imprecision estimates below 10 nanograms per liter, which could be used for sites that are adopting and utilizing a high sensitivity assay. And so perhaps not every lab can actually, derive the upper limit of normal 99th percentile or obtain a large sample size of healthy individuals with appropriate exclusion criteria to assess the true nature of that assay being a high sensitivity assay. But one thing that all laboratories can do is actually measure a concentration below 10 nanograms per liter or below the 99th percentile in order to see whether or not it meets acceptable analytical performance. So, and this leads to our recommendation one. For high sensitivity assays, laboratories should measure at least 3 different concentrations of quality control materials. And most importantly, when we think about that, again, we want to report nanograms per liter. And for quality control, we'll always report to 1 decimal place. Obviously, for patients, we report in whole numbers, but for quality control, we're going to do 1 decimal place. And most importantly, the one level of quality control material that we've advocated laboratories do is use a concentration between the limit of detection and the lowest sex-specific 99th percentile. So for most instances, that's below the female 99th percentile. So this is actually a normal concentration. So that's one thing that laboratories can do. And if you're able to measure a high sensitivity assay in the normal range with appropriate precision, you should feel comfortable and there should be confidence on the utility of that assay and its proposed clinical benefit for patients as well. So what does that mean when we actually measure a quality control material down below the 99th percentile or normal level? So here in this slide, I just want to highlight the fact that, again, we manufacture our own quality control material for the last number of years. And here I want to illustrate 3 different materials that we manufactured. And what's important here is that we looked at 2 different laboratory sites. And so what we've seen of a period of nearly 2 years is that laboratory 1 was actually measuring differently than laboratory 2. Again, very similar. This was close to 1 would be mean, and this would be close to, this would be close to 4, and this would be close to 5.5 or closer to 6. So there is a little bit of offset here. And why that's important is that there are some algorithms, which will be alluded to later, that use a common low cutoff in order to perhaps identify patients at low risk or perhaps could be used to rule out an MI. And that's okay if it's just at 1 hospital. But if there's 2 hospitals in your system and the assays are running this different apart, then it becomes very difficult to see what's the most appropriate cutoff because, again, one site's running differently than the other. However, as you can see over the period of years, the 2 analyzers, the 2 sites actually became greater agreement with each other. And so now, obviously from 2017 to May 2019, we can see that both site 1 or analyzer 1 and analyzer 2 are running equivalently at this level. And again, we kind of support the fact is now we probably can use a common cutoff and report that and use that, or clinicians could feel more comfortable of acceptable and agreement between analyzers and sites because we are actually now achieving the same type of precision and same type of measurement performance down low. So again, without actually measuring quality control material below the 99th percentile in the normal range, laboratories will not be able to inform clinicians whether or not there's agreement at the low end, which again can be used for early decision making in the ED. So is this just relevant for one assay? Well, no, it's relevant for majority of high sensitivity assays that you're able to monitor the assays using the low concentration, low normal concentration, as well as 1 near the 98th percentile. So here we did a comparison between Abbott high sensitivity troponin I versus Beckman's high sensitivity troponin I. Here we see concentrations we receive a low normal concentrations 5.1 with the Abbott at one of our sites, whereas at the Beckman it's going to be a little different at 3.9. But importantly, the precision and the SDs at both of these sites and both of these levels are acceptable for performance. SDs are 0.8 or lower, and here for Beckman's 0.3. So again, one can measure a low normal concentration with a high sensitivity assay and achieve appropriate precision goals only when using a high sensitivity assay. And then when you look at a concentration near the male 99th or near the overall 99th percentile, one can also realize acceptable, very tight precision, well below 10%, with, as you can see, with the Abbott assay and as well with the Beckman assay. So for example, it's 23.6, an SD of 1.0, and CV of 4.2%. So again, analytical performance for the high sensitivity assays, if you use the recommendations in using normal concentration for quality control, as well as one near the 99th percentile or upper 99th percentile, in which case most of that is males, 99th percentiles, you can actually achieve excellent analytical performance. And so this is something that should provide confidence for laboratories when releasing and reporting results with high sensitivity assays. However, it's important to note that this is sometimes a challenging endeavor, and sometimes the problem could be with the quality control material and not necessarily your assay. So you want to be mindful on selecting quality control material that is benefit to your assay and to your laboratory. So here's an example where here's our patient pool near the 99th percentile. Here we see again CV of, the mean at 34, CV is at 3.2%. So this is near for the Abbott assay, this would be near the male 99th percentile. So excellent excellent performance with a CV of 3.2%. So at the same time, we measured another quality control material at the same time. And so what we see here is obviously the concentrations are a little bit different. But what I want to draw your attention to is the CVs has increased. So the imprecision with the quality control material, the commercial quality control, is actually higher than it is on the patient pool material. And so this wasn't just, this was obviously evident while we did our crossover. This was also evident when we went with this quality control material to see afterwards. We see the same type of imprecision stays at 7.5%. And this is just not obviously, specific for one assay. And when we use another high sensitivity assay, we also achieved somewhat suboptimal precision estimates. So it is important that laboratories, select the appropriate quality control material. Note that sometimes the precision may be sometimes may be over stated, or perhaps could look worse than what it is for patients. But the fact of the matter is laboratories need to monitor their assays at the lower end, and as well obtain appropriate quality control material and appropriate rules such that we can mitigate any analytical variation that could impact on patient outcome. So the other recommendation that we made in the joint document was that when sites go to a high sensitivity assay, that they should at least validate or look at the LOD and the LOB. And again, this is not necessarily applicable worldwide, as presently the FDA only allows reporting down to the limit of quantitation. So how would one go about doing this in regards to perhaps assessing, is my low end appropriate? Am I really reporting undetectable concentrations if I'm measuring a sample with no known analyte? So I think it's really not a trivial matter, and the fact is that there's going to be variation and differences on what materials are used in assessing, say, the lower limit of reporting. So here's just an illustration with 3 different high sensitivity assays where, for example, we want to determine what the lower limit of the blank was. And so this is a material without any troponin. So one material that doesn't have any troponin is water. And so if you ran water 60 times on the Abbott assay, you get 0.6 nanograms per liter. That's the LOB. So again, this is the noise that's related to just material without any analyte. So I think we'd all agree water doesn't have any troponin. But when you actually start to measure water on different high sensitivity assays, you're starting to see some measurable concentrations. And so one may question, well, maybe these aren't high sensitivity assays. And that's not really the case. The fact of the matter is that majority and most of the high sensitivity assays over the number of years have been reformulated to obviously determine the amount of protein that's in a patient sample, and they've optimized the testing to replicate what's in the patient sample. So obviously patients don't have water running through them. They are actually plasma, and in plasma there's a lot of protein and so forth and so on. So when you actually do use a more appropriate material, so for example, Beckman, if you use the sample diluent, you get a very reasonable LOD of 0.5. And for the Siemens EXL assay, if you use a zero calibrator, you get a very low LOB of 0.9. So again, one thing that laboratories could do is the fact is that you may want to just to make sure that your assay before implementing, or we make a recommendation as well, is that you want to yearly check and challenge that the low end is really reporting undetectable concentrations. If you can't use water due to non-specific binding, then you may want to assess the sample diluent, and if that doesn't work, then you want to look at the zero calibrator. So at one time, labs should be at least monitoring, assessing that indeed they are able to report undetectable concentrations. But the rate and the way that labs do that is actually dependent on the high sensitivity assay that they use. So now going on to objective 3, what are some of the strengths and weaknesses possibly of earlier testing protocols for high sensitivity cardiac troponin testing in the emergency department? So again, this was nicely highlighted in the 2015 ESC guidelines, where data mainly from the PACE study group and important studies that have been done out of Europe, multi-center studies, they've devised a very early rule-in and rule-out algorithm where troponin can be measured over a period of 1 hour in order to either rule out patients or rule in patients for myocardial infarction. So again, at the time of this publication, only 2 assays were actually had regulatory approval. I would not focus and do not focus on this assay down here because that was just a research assay at the time. So how would this work? So for example, they have the Roche Troponin T assay and the Abbott Troponin I assay. So I'll just focus on the Abbott Troponin I assay because there are obviously different companies that have also have their 0-1 algorithm derived from that, and it's all looking at Troponin I. So how does this work? So a patient comes in with obviously a clinician, all sorts of clinician clinically assesses that patient and believes there could be possibly some symptoms suggestive of acute coronary syndrome. So they're going to measure troponin. So in this algorithm for Abbott's assay, if the 0-hour troponin is below 2 nanograms per liter, you can rule out MI. And or if their 0-hour, their presentation sample, is less than 5, and the change between 0 and 1 hour is less than 2, you can rule out. So here's an example that can be used for, say, the Abbott assay. And on the opposite side, to rule in, if a patient comes in with very high values, greater or equal to 52, or a change of 6 nanograms per liter over 1 hour, you can rule in. And so these are obviously have been obviously validated and are used throughout Europe and across the world. And now we can see that there's algorithms for the Abbott assay and obviously Troponin T for Roche, but we see it's also for the Siemens, the Beckman assays, and the Ortho assay. So these are very much some clinicians like these approaches because they can use this for early decision making in the ED. And so in the laboratory, one thing you want to be mindful of is how robust are these criteria? How robust is a less than 2 to rule out? How robust is a change of 2 to perhaps rule out, or a change of 6 to rule in? And so these are important information that laboratories should be doing and assessing so that they can provide some, when consulted to clinicians, they can provide some evidence and some advice in regards to changes at the low end, because these are all absolute changes that are used for early decision making. So the first thing that laboratories need to be mindful of is that there is definitely variation near the lower limit of reporting. So here's a publication in clinical chemistry where we looked at external quality assurance testing. So this is with the Abbott assay. So at the ESC cutoff of 2 nanograms in order to rule out MI with the Abbott assay, so there were about 30 sites. It was almost a 50-50 split. So 60% of the sites reported less than 2, and 40% reported 2 or more. And you can see that in this type of diagram where, for example, we have some sites that are reporting at a 2 or less than 2, and then we see some nice variation above them. Importantly, even though they are high sensitivity, some assays have reported, say, less than 10. So again, clinically, it's important that the laboratory appropriately reports high sensitivity troponin assays use the right lower limit of reporting, because clinicians could be easily confused to say, well, my troponin's undetectable, I can send them home. If they were, say, at this site that uses less than 10, that's inappropriate. And the fact is that, as we know, there's perhaps measurable concentration in that patient. And so the more appropriate aspect is reporting down to the lower limit of detection, if at all possible. But again, even here, we'll see that there's a variation. So there's nothing that can be done here for the most part, but it's important that you relay that information to clinicians. If a patient, say, with the Abbott assay comes at 2, it's a flip of the coin if it's really 2 or below a 2. So the other thing that laboratories need to be mindful of, again, using these algorithms at low troponin concentrations, obviously the variability, which was just highlighted, but another thing that we need to be assessed is interferences. So here's a publication back in 2010 where the investigator looked at the effect of hemolysis on troponin T concentrations. Now on the ESC01 algorithm, if the patient's sample is less than 5, they can be ruled out. So here's a concentration at 6 nanograms, and as you can see, with a little bit of hemolysis in that sample, there's a 40% decrease in troponin T concentration. So again, what was a 6 and would have placed that individual possibly in the observational zone or perhaps wouldn't be ruled out at the emission sample, if that sample was hemolyzed, it would drop below 5 to about 4 nanograms per liter, and so they could be ruled out. So again, it's important that laboratories look at that aspect, and if there is hemolysis or if there's an interference that could impact the concentrations at the low end, that laboratories appropriately report that information out to clinicians so that there's no patient misclassifications. However, it's very important that these types of interference studies are just not, a generalized statement that hemolysis leads to lower concentrations. It has to be assessed per assay. And so here you can see that if you looked at, say, 2 high-sensitivity troponin assays with different concentrations of hemolysis, there really is no appreciable effect at a low concentration of troponin. So this would be all low normal concentrations of a 5 or 3 or what have you. You're seeing no differences. And that's for hemolysis and that's for icterus. So it is important that laboratories do assess or at least make note of the fact is, do these common interferences, hemolysis and icterus, do they impact interpretations or do they impact analytical variation at the low end? The other thing that is obviously been highlighted even in the earlier recommendations is that you don't want to use different sample types. So it's really important that laboratories only accept one sample type when patients are being evaluated for, say, is this patient having acute myocardial infarction, what have you. And the reason is as follows, is that there are sometimes differences between different sample types. So in this example, and this is with the Abbott assay, what we observed in this study was the fact is that troponin was proportionally higher at higher concentrations with the Abbott assay as compared to EDT plasma. So again, highlights the fact is that you just want to keep the same sample type because clinicians are looking for changes in concentrations. Some of that is absolute, some of that is percentages or relative. Needless to say, you don't want to have a heparin plasma on the same patient. You don't want an EDT plasma one time and then a heparin plasma at the second time measurement because you'll see variations due to the sample matrix and not necessarily anything to do with the changing in patient concentration of troponin. So again, it's really important that laboratories only accept one sample type while testing, especially for patients in the acute care setting. Well, are there other things that can cause variation and misclassifications of cardiac troponin? And one of the things that we've observed, and this was published in 2018, and this is for many different high sensitivity assays, both Abbott, Beckman, and Roche, is when we did a comparison between Abbott and Beckman, and we did several different measurements. So here's Abbott high sensitivity that was clinically reported, and we took these samples and we measured it again for the Abbott assay and again for the Beckman assay on the axis too. So we see that there's reasonable agreement between the assays. However, there are a number of patients where Beckman reports significantly lower results than Abbott, and I just want to highlight patient one. So patient one came in with syncope. These are the concentration. These were the times of draws for the Abbott high sensitivity troponin assay, and so here we see a 1500, and then it went to 1300, and then went to 1354. So sample number one we obtained at this time frame, 1354, 1,354 nanograms per liter. When we repeated it on another analyzer on the Abbott assay, we get 1,447. But surprisingly, when we ran that sample with the Beckman assay, it was only a 12. And so this is well below the 99th percentile, and obviously this was a male, so even below the male 99th percentile. So, but when we measured on the Roche, we got a 65. What we actually ended up doing was doing a PEG precipitation because we were suspecting perhaps this could be a macro complex. And there are two types of macro complexes, but for the majority of troponin assays, when we think of macro complexes, we're thinking of immunoglobulin-based complexes that are formed. So when we did a PEG precipitation, we measured it on the Abbott assay, we see that the result now was only 4. So it's only 0.3% recovery. Typically less than 20%, you would say that there's a macro present. And then we actually measured CKMB on an earlier sample. We actually obtained a normal result. So here's an example where we can get very different results, and clinicians, will have to do serial measurements and they're not seeing any changes. And part of the reason for the discrepancy or lack of change may be due to a macro complex, which may not be why that patient came in and may not be due to an acute condition, what have you. So again, macros could produce widely different results, and something that laboratories need to be aware of. It's infrequent, but they could occur. Also, to illustrate this point was again another publication in the March issue of Clinical Chemistry this year, looked at Lamb and colleagues from New Zealand, looked at a group of patients from the community, not in the hospital, that had troponin requested to be measured. So there was about 241 individuals, and of these individuals, they basically performed this evaluation to see whether or not there was a macro or not. And so, but at the end of the day, there's about 100 or about a little less than 50% of them where they didn't have a macro, which means that almost half those people that submitted a sample actually had a macro. And so on the right-hand side, here's an illustration, different high sensitivity assays, and the authors actually came up with this nice terminology when there's a macro complex. They call it macro-ic. So this is where there's just a macro, immunoglobulin bound to troponin I, or perhaps a troponin I-C complex. Macro-tic, which is obviously immunoglobulins bound to all three, troponin T, I, and C, perhaps with the complex without being degraded. And also could just be macro complex for troponin T. But when they looked at, say, the macro-ic, which is up here, or the macro-tic, which also included troponin T, what they actually observed was that assays that actually had 3 antibodies in regards to their design in order to detect and measure troponin, what they observed was that there were more, the majority of those assays actually had a higher percentage or higher number of macro complexes detected. So for example, here we can see both Siemens assays use 3 antibodies in design. Close to 80% of the samples of these 89 patients had concentrations above the 99th percentile, whereas other high sensitivity assays, and as alluded to in the earlier slide with Abbott, with Beckman being lower, Beckman also had lower recovery of these macro complexes. So the authors make an interesting observation to say perhaps there's higher immunoactivity for macrotroponin I when using a 3-site antibody based upon these data. So we have looked further into this to see if that's really the case. And so here's just an example of a case that was brought to our hospital in regarding because the clinicians and cardiologists were, were assessing whether or not this elevation was due to a macro complex or whether there's something else going on. So here's a case, 48-year-old female, final diagnosis of non-cardiac chest discomfort, coronary CT angiogram was fine, and there's no evidence of atherosclerotic disease or coronary stenosis. So looks like cardiovascular side is all good. A plasma sample was submitted to the laboratory to investigate if a macro complex was present. Cardiologists suspected it because the values were high and unchanging. We performed this via the PEG precipitation. So the initial result on that patient, the sample that was submitted, was 130 nanograms by the Abbott assay. After PEG recovery, it was less than 0.5%. Result was 0.6. So again, this is well below 20%. So this is suggestive of a macro complex. We took the same sample, measured on the three-site immunoassay. And so this one, we looked at the Siemens EXL high sensitivity assay. Again, three-site immunoassay, and the result was, again, 213 nanograms per liter. So again, a high sensitivity assay, three-site design, yielded higher concentrations than a macro. But this is not always the same case. Here we looked at that same sample with ortho assay, it's also three-site immunoassay, and now it yielded a result of 4.5, or a normal concentration on that patient sample. So again, illustrates the fact is that clinicians need to be aware of macros. Laboratories, when they are approached or consulted regarding the presence of these complexes, they need a plan in place in order to try to rectify and resolve these issues. And it may not be so simple to say that, oh, I have a three-site assay, of course I have a macro, or maybe the fact is that a two-site assay doesn't have a macro. There are more factors into play, and so one thing that is obviously the case is that there should be some caution that the makeup of these complexes is going to be very, very different, and they're going to interact differently with all different assays. And so at the end of the day, laboratories need to be aware of this, and if are approached by a macro, need to be able to provide some evidence, provide some interpretation that could be provided to clinicians, and also a plan in place to rectify or resolve these issues such that in the future, when these patients represent or what have you, that interpretation can be done appropriately. So that was on a real life case sample, but what about in stored samples? So the one thing is because it's immunoglobulin based, for the most part, immunoglobulin based binding to troponin, this may be present in stored samples. So here's a publication just earlier this year where we looked at some patients in a clinical study, and we looked at measurements of high sensitivity troponin. So here we have two patients, patient 1, patient 2. And I just want to highlight the fact is that here we see that the concentrations, bolded are when they're above the 99th percentile. And just for illustrative purposes, I use the overall 99th percentile in these analyses. So both patient 1 and patient 2 have concentrations above 99th percentile with troponin T. For Abbott, at the time on the I-1000 analyzer, in 2013 when we measured these samples, there was one that was above 68, quite high, 68 and 69. Interestingly, when we actually measured these same samples on these patients with the Beckman assay, the regulatory approved assay, in 2017, we actually obtained normal concentrations of 4 and a 7, as opposed to a 68 with the Abbott assay, it's only a 7. When we actually measured the Siemens ADV assay, we also had some elevations above the 99th percentile. But then when we measured the ortho, which is a three-site assay, three-site immunoassay, we also had low recovery of the of troponin, indicating that these results may be due to a macro. Importantly, we then measured the same sample again on the Abbott, and now we have an elevation above 37, at 37, which is above the 99th percentile on both patient 1 and patient 2. And when we do a PEG precipitation, we actually get very low recovery. So these data illustrate that indeed macros, even in clinical, can exist for a long period of time, are evident and stable in samples that are stored, frozen, and so forth, and undergo multiple freeze thaws and what have you. And so again, it's important that laboratories are aware of this and have plans and procedures in place if confronted by clinicians as to, or clinicians that are questioning the pattern and the elevations in certain patients when measuring high sensitivity troponin assays. So is this important to know, and is it important to interpret this information? It may well be, because many of the studies that have been done on high sensitivity assays, there are some done in real time, but a lot of them are done in frozen samples. And so here's an example of a patient that was adjudicated as an MI by missed with a high sensitivity assay, the 0-1 algorithm. So when you actually look at this patient, it was adjudicated to have an MI because the troponin, which was done by a contemporary assay, were high, as 85 at presentation, and then it fell to 79 18 hours later. So clinically, during the study and adjudication, they determined that was enough to say that there was acute myocardial infarction. But when you look at this individual and you look at the troponin levels that have been provided, you can see with troponin T, it starts off an 8 and stays 8, 7, 7, 7. So the results are quite low, and they're all normal with this patient. When you actually look at another high sensitivity troponin I assay, you are also getting very low concentrations, well below the 99th percentile. And even with the Abbott high sensitivity assay, yes, if you use a sex-specific cutoff, this would be high, but one could question whether or not there's really changes in these concentrations at all. So again, obviously this is just suggestive because there's been no macros measured in this patient, but I think it's important that when we think about why one assay works and when one assay doesn't work, or obviously all assays work, but when there's differences in interpretation, whether or not they're missing, say, a clinical event versus not missing a clinical event, I think we need to be mindful of is there perhaps other factors at play analytically that may have caused this differences in assays performance. So with all that being said, what is the clinical utility or safety of using the ESC01 algorithm? So here's a systematic review that was just published in the journal Heart. Here are different troponin, high sensitivity troponin assays, obviously by the different studies. And here is the forest plot, and they basically look at the sensitivity. So there are two metrics that people look at when regarding whether or not whether it's safe to rule out is the sensitivity and negative predictive value. And for sensitivity, a lot of emergency physicians have recommended that the sensitivity needs to be 99% or higher in order to safely rule out. And so, as you can see here with these assays and these publications using 0-1 algorithm, the sensitivity approaches 99. The point estimate of sensitivity is close to 99th percentile. It's not quite there, 99%, sorry, not 99th percentile, but it's close to the 99%. And so the authors say that, looking at this meta-analysis, various different studies, the results support the use of the 0-1 algorithm. However, the algorithm may not be sufficiently safe if 1% miss rate for myocardial infarction is desired. So again, there's a little caveat there, and so there'll be differences in clinicians will interpret these data differently. So sensitivity is what one metric is used, but another metric that is used is negative predictive value. In that setting, some have advocated a negative predictive value greater than 99.5% is sufficient in order to rule out. So again, something that needs to be discussed with clinicians, aware of these data, aware of the performance, and that they are, and as a laboratory, if they are using these types of algorithms in clinical practice, you need to make sure that you have appropriate quality control procedures in place and quality assurance procedures in place to try to mitigate any inappropriate testing. So, as you may also recall, that's to rule out, but what about ruling in? Well, so for the Abbott assay on the ESC guidelines, they say a change of between 0 and 1 hours of 6 or more is sufficient to rule in. And so just want to highlight the fact is that when we took the same sample and we measured it 8 times, so same sample just measured 8 times, different analyzers, we can see that yes, majority of them repeat exactly the same concentration, but we can see here that there are some, repeats on measurements that exceed 6 nanograms per liter just due to the variation in testing. So for example, on this patient, average was 17 nanograms per liter. The lowest one observed was 13. The greatest one observed was a 20. This difference is 7. So it kind of illustrates that even with high sensitivity assays that are appropriately controlled, you can see this variation when the changes are just 6 nanograms per liter or even lower at 4 nanograms per liter, which is illustrated here using quality control material and measurements over 20 minutes. We see that there are drops in measurements. And so again, it may be difficult when using small changes to rule in for laboratories to be confident in the performance of their assays. So there are other algorithms besides the 0-1 algorithm in order to use for high sensitivity assays. There's 0 and 2 hour algorithms that have been developed obviously for both Roche and for high sensitivity troponin I assays. And this publication highlights its use in the Beckman assay. There's also the high stakes pathway, again demonstrated with the Abbott and with the Siemens assay. And finally, there are other approaches such as the Compass MI, which looks at 2 measurements and changes between them. And this was obviously published in New England Journal just last year, and this looked at both Abbott and Roche assays. So are there other algorithms can be used? Yes, there are other algorithms, but all the other algorithms use some clinical information. And so here's a nice publication from Louise Collins' group in Australia looking at various different clinical pathways. And so the one pathway that they look at, clinical pathway, is the no objective testing rule. And here you can see if you have 2 measurements below the overall 99th percentile, in this assay, in this case it's the Beckman's assay, there's no ischemia on ECG, the NOT score is 0, and again, in order to get that, there is some age and clinical information that is needed. But if that is employed, one can actually achieve a sensitivity greater than 99%. So again, using clinical parameters in addition to high sensitivity assays in specific rules, one may be able to achieve a sensitivity above 99%, which is illustrated in this nice publication from Australia. What about just using 2 troponins? And so this was the Compass MI, and the reason why it was called Compass is the fact is that different sites may achieve different types of performance. And it's a little bit complicated, but it's going to walk over an example. So for sites that were using an early protocol, so the second sample collected anywhere from 45 minutes to 120 minutes or less than 2 hours, and this is just an example for the Abbott assay, so if the presentation sample is less than 6 and the change between the baseline or 0 hour and the next sample between 45 minutes to 2 hours, less than 2 hours, if it was less than 4, so I get presentation 6 and then the change is less than 4, one would be able to identify nearly 60%, in this case 57% of patients can be ruled out for MI. That's in this area right here. And here we're going to have less than 0.2% of those individuals actually have a 30-day MI or death. So that's a rule out. So you can see you can nearly get up to 60% of patients by using this protocol. On the flip side, if someone came in with a troponin greater or equal to 30, with a change greater or equal to 7, so higher than the ESC6, what we can be able to do here is the fact is that we actually see 21% of the patients can be ruled out. So in this type of approach, one can really start to optimize based upon obviously clinical preference and site preference as to what sites believe are appropriate cutoffs they can monitor and measure, as well as clinicians regards to safety, negative predictive value or sensitivity. One can really optimize high sensitivity troponin testing and the deltas in order to rule in and rule out individuals very promptly in the emergency setting. So how about a one and done approach? So there may be some issues when looking at very low concentrations near the LOD, and again, analytically, there's going to be some variations. But what about at higher concentrations? And so here's a publication published in JAMA at a 5 nanograms per liter concentration of the high sensitivity troponin I. This is with the Beckman assay, with the Abbott assay, but a lot of these cutoffs have been also that 5 nanogram per liter has been obviously used for other high sensitivity troponin assays. And here you can see with negative predictive value that the summary statistic NPV is 99.5%. So regardless of if the MI was adjudicated based on a contemporary cardiac troponin or cardiac troponin T or with the high sensitivity assays, the overall summary statistic is a negative predictive value of 99.5%. So at least on that aspect, if clinicians are comfortable on that metric, they'd feel maybe useful, or maybe they'd find this approach of 5, less than 5, in order to rule out. However, if you use other common laboratory parameters such as glucose, EGFR, in addition to a very low troponin measurement, one can see that here, just by ruling in, ruling out 30-day MI death, here in over 4,000 patients, what we observed is that, we're close to 99% sensitivity, 99% negative predictive value when using less than 5. But the sensitivity is below that. It's only about 97%. However, if we add these other parameters in here, we can increase the sensitivity above the 99th percentile. So there are perhaps ways that we can further improve the assay or the clinical sensitivity by incorporating A, other laboratory variables, or B, which was demonstrated by Louise Collins' groups, perhaps we can use other clinical algorithms to optimize the performance to achieve both a high sensitivity and high negative predictive value, well above 99% for both. So this leads to the last little bit of the talk in regarding high sensitivity patients, high sensitivity testing in patients with COVID-19. Again, this is an emerging area, but I thought it'd probably be worthwhile just to highlight a couple studies that have been recently published looking at this. And so the one large publication out of China actually nicely demonstrated serial measurements of high sensitivity troponin in patients that survived, so that's the blue, versus those who did not. And so the one thing that's actually pretty noticeable as a fact is that patients that actually survived, the median concentrations for high sensitivity were quite low and remained low, well below 5 nanograms per liter, whereas those that had a bad outcome, you can start to see that the high sensitivity troponin started to rise, obviously probably in conjunction with a worse clinical condition of that patient. So that was illustrated in one population. In another population, we looked at, again, patients that obviously, unfortunately, died versus recovered. And if you look at the high sensitivity cardiac troponin assay in this publication, we also see that the patients who did recover at presentation or admission, their high sensitivity values were quite low at 3. Whereas those who did not had very high troponin assay. And so there's been a greater realization that, especially with patients with COVID-19, their cardiac injury, cardiac dysfunction, cardiac heart failure, among other things, cardiac injury and other aspects related to the heart are quite prevalent and is something of interest, especially when assessing and interpreting these values. So one thing that is known so far, and again, there'll be more data out here, but if you look at the data to date with with cardiac troponin, it's really important when consulted by clinicians that labs are familiar with what a high sensitivity assay is versus not, so they can inform if the publication was using a high sensitivity assay versus not, and what are the findings. And so definitely with cardiac troponin, many studies to date have suggested that obviously very high values or values above the 99th percentile are not very good for patient prognosis. And I think it's important to say that, both contemporary assays and high sensitivity assays are definitely appropriate for detecting myocardial injury. However, data to date may suggest a further utility of high sensitivity troponin testing because you may be able to detect low normal values, which actually indicate a favorable prognosis for that patient. This has actually been nicely, you know, illustrated by an opinion article by Nick Mills and his group that talks about high sensitivity cardiac troponin can be an ally in the fight against COVID-19, and this is freely available. I encourage those who are interested to read that. And there are other publications that are in the works that also discuss possible utilities of high sensitivity in the setting. So in summary, just want to illustrate or reiterate that detectable cardiac troponin concentrations in the majority of the population is an analytical hallmark of a high sensitivity troponin assay. Again, when you are going and you're using a high sensitivity assay, you need the right QC. Obviously, you need something around the normal. You need something in the normal end, normal range, in order to make sure that you're monitoring your assay appropriately. You want the right sample type. You don't want to accept different sample types during the course of, say, a patient who's in the emergency department, because you'll see variation. And most importantly, you want the right lower limit. Because if you're reporting inappropriately low end, clinicians may inappropriately discharge patients or rule out an event when in fact they may still have an event occurring. Other things that are important, there are actually now performance goals. There's more commercial quality control that's available to monitor high sensitivity assays, and there's established error goal, allowable error estimates that can be used when measuring high sensitivity assays. There are assay-specific issues, and so sites and laboratories need to be mindful of pre-analytical, analytical, and post-analytical factors that may affect, obviously, high-sensitivity interpretation. And lastly, I probably can't state this and emphasize this enough, know your high-sensitivity assay, the one that you're running, because all of them are a little bit different. And the earlier testing protocols and risk stratification approaches that can be achieved with high sensitivity troponin testing really need to be evaluated regarding to what is your assay, where's the evidence, where's the data, in order to utilize and that test for best patient care. So with that, I'd like to thank you for listening, and obviously for all the collaborators and for funding I've received over the years, and specifically from the Canadian Institutes of Health Research, who's funded my work in cardiac troponin for the last 15 years. With that, I'll end my presentation.
Thank you, Dr. Kavsak, for sharing your wonderful presentation with us. We will now begin this webinar's question and answer session. First question is, can you share your thoughts on the evolution of the Beckman high sensitivity troponin 1 assay?
Yeah, so it's interesting because our first publication on high sensitivity troponin I was in 2009, and that was on the prototype, the original Beckman high sensitivity assay. And so even with that prototype assay, when we measured material near 10 nanograms per liter, which again is only a material that can be, that concentration can only be measured with a high sensitivity assay, even with the prototype assay, we achieved a standard deviation of about 1 nanogram per liter. So it was less than 10%, or about 10% at 10 nanograms per liter. And, what's surprising to me is that over, the next 12 years or what have you, or 10 plus years when we started measuring different versions of the high sensitivity troponin assay, we've also always been able to obtain that very tight precision at the low end. And, it was illustrated in the latest high sensitivity assays where now we still are achieving standard deviations below 10 of less than 0.8. So that's one thing that's been very gratifying to see, is that over the last, over the course and evolution and development of high sensitivity assays, that the precision's always been there, the tight precision down in the normal end. The other thing is it's been quite remarkable as well, is that some of the aspects in regards to perhaps interferences or something that would perhaps cause confusions because of high concentrations. And for this, I just want to highlight perhaps the macros. There have been some assays, and we've definitely demonstrated this with Beckman's assays, is that over the development of the high sensitivity assays, some of these macro complexes are no longer detected with the high sensitivity, the latest regulatory approved high sensitivity assay, which would be of huge benefit if a patient's coming in suspected with perhaps is this an acute coronary event, are they having an MI, having an assay that's not perhaps impacted by macros, it could be very useful in this setting. And so that's one of the pleasant surprises is over the years, some of the interferences or some of the ways that assays have been redesigned haven't don't detect macros at the rate that they once did. I think it's also important just to clarify or the fact is that we really don't know the clinical relevance of macros in this setting per se. So we need a lot more work, and it's kind of illustrated in the talk is that these could be confounding variables when patients come in with chest pain. Are they having an acute event, they have an elevation, but is this really driving, is this really the hallmark or is this really the signal for an MI? But it may not be the acute situation, but we don't really know what is the long-term outcome on patients with macros. And so in the short-term setting, not an assay that doesn't have an effect with a macro may be a good thing, but we need to evaluate and do further follow-up studies regarding to what's the clinical relevance of macros.
Thank you. Next question is, can you elaborate on the analytical performance aspects related to Beckman's assay?
Yeah, so the one, as it just alluded to earlier, is that the one thing that's been constant is the fact is that, with definitely the different versions of the Beckman assay over the past dozen years that I've looked at, from research to enhanced versions to the regulatory approved version, one is able to achieve excellent performance down low, very lower limits of reporting, very good precision at normal concentrations, and that is definitely what's important when we're looking at high sensitivity assays. That's evident for Beckman, but I'll make the statement I've seen this for all the high sensitivity assays where we're able to now achieve excellent performance at the low end with all high sensitivity assays that are regulatory approved, which is what is needed if clinicians are going to start to use these values in order to make early decision making in the ED.
Thank you. Next question is, how robust are Beckman's assay 0-1 and 0-2 algorithm?
Yeah, I mean, I didn't have the opportunity to go through all the different algorithms and to see which ones are perhaps more robust or which ones may be more susceptible to analytical noise. Clinically, they may work well. There's publications that say they work well, but in a laboratory, you should be looking at your assay and seeing, okay, well, how robust is the change criteria? How robust, how well can I monitor, say, the low cutoffs to do that? And so it's important that labs look at that. So I talked briefly about Abbott, but and there may be some, performance issues that laboratories need to be aware of if they're, utilizing, say, the Abbott assay for the 0-1 algorithm. But they're all achievable, and if strict control, the labs can do that. But there may be other. So, for example, the Beckman assay using the 0-1 or 0-2 algorithms. The first 0-1 algorithm actually has change less than 4, which is very similar to what we've seen with obviously the Compass MI having a change less than 4 for early rule out. So again, a change less than 4, that again is something that should be, especially at lower concentrations below 10, a difference of 4 is really a different. It's not due to analytical variation or minor biases. It's probably due to the patients, having more troponin in there, just because it's typically outside of our analytical performance goals. So again, with the Compass MI, we see a change less than 4, and even with Beckman's 0 1 hour algorithms, we see change less than 4. So again, that type of metric at the low end is something that is, probably some of the labs can monitor and feel comfortable to saying that I can measure accurately down low, and I know a change of 4, say below 10 or what have you, is probably something that indicates a difference. And again, typically what's also occurred is that as you go from the 0-1 to 0-2 or 0-3, typically the delta increases. And so if you're good with the 0-1, the change of 4 or what have you, then the 0 and 2 hours, usually a higher delta, and there should be definitely greater than the analytical variation, and that's also observed with, for example, the Beckman, the 0-2 assay, 0 and 2 hour algorithm. The change there is less than 5, so you have to have differences less than 5. You can also at the low end. So again, those types of algorithms where you're able to monitor, feel comfortable, may be of use and may allow labs to feel comfortable in reporting some of these assays down low if clinicians are using them in that manner.
Wonderful. Next question is, can you discuss the impact of sample types? And does China allow more than one sample type for the assay?
Yeah, I mean, that's the thing is that, it's just you don't want to mix different sample types when a patient's coming in. You want to make sure that the same sample type is used for measurement of the troponin, high sensitivity troponin, so that you don't add other variabilities, because we are looking at these small changes and so forth at the low end, or even at the higher end, we're looking at changes as well. So you want to mitigate that by just looking at the one sample type. So typically that's what should be done. Now, part of your investigations, if a clinician questions that there may be something that's not making sense, it's also important that labs have looked at different sample types. And so not necessarily you want to report this to, say, clinicians, but part of your internal investigations, if someone is saying, I have an elevation that doesn't make sense or what have you, sometimes what you'll see is that measurement in different sample types may be useful in order to identify if there's an interference that was there that could have contributed to that, say, that discrepant result or what have you. And so the ability to measure high sensitivity troponin in more than one sample type is important for the lab so that they can, perform additional testing if they are getting calls or if they're getting clinical inquiries regarding discrepant results due to the clinical picture. And so that has been demonstrated as a benefit for many different high sensitivity assays. And we did publish a paper in Clinical Chemistry and Laboratory Medicine looking at the effective matrices on Beckman's and Abbott assays and how that can be useful in identifying discrepant results. So something that labs don't want, to accept all different sample types from patients that are coming into, say, their hospital with potential chest pain. Only, accept one for clinical reporting. But in the event that there's some sort of clinical concern or questioning some of those results, labs should be, have a protocol in place to, start testing with different sample types on that patient, and so that on that patient where the clinical concern or query came in, so that you can start the process to see, okay, is there an interference? And sometimes the first step is just measuring the troponin in different sample types. And if you see wildly discrepant results, that may tell you that there's something that could be contributing to that discrepancy.
Wonderful. And last question is, can you elaborate on macro complexes and how Beckman's assay is less affected?
Yeah, so there are, as alluded to, this has been documented in the literature for a number of years. Even with the contemporary assays, there has been some reports of macro complexes, and so. One of the caveats was because you don't know if it's a macro complex unless you start to do investigations. And so, and you never get alerted to that typically in the lab unless a clinician starts to, do further investigations, they can't understand why there's an elevation. But in absence of all that, if someone comes in, and again, if it's an acute coronary situation or acute cardiac injury, using change and differences in concentrations of cardiac troponin, that may be very useful as well. And that, so even if a patient does have a macro, also looking at that change, because, there may be a macro, but there's also other troponin that's coming out from the heart, and you'll start to see the rise and fall. So it's not the fact it's still important, and if you see an elevation, it's still important to do the serial testing to see if it's for certain patients to see if it's increasing and decreasing. And that may be useful in the acute situation and setting. And those are some of the queries that we get, is that patients come in and they get admitted and they do the workup and they go, it doesn't really seem like there's anything wrong with the heart, and I can't understand why the troponin is elevated. And so it's part of the laboratory's responsibility to work with clinicians to try to provide some solutions to their clinical dilemmas. So what it does appear is that in the evolution of high sensitivity troponin testing, there does appear to be some complexes that aren't detectable by some assays versus others. And again, it is really surprising. It was really nice to see from the prototype Beckman assay to the final version that some of these macro complexes went away. We weren't detecting them with their contemporary assay, and so with their contemporary with their high sensitivity approved assay, we didn't see that. So that may be a benefit, because you lose that confounding variable. The high troponin comes in, you're not seeing these high troponin concentrations with some of with some high sensitivity assays. So that could be a benefit. I still think we don't really understand why do some patients develop a macro complex with troponin. How long do they persist in patients? So if a patient has a macro complex today, because there's some antibodies bound, does that patient comes back? Do they, a year later, do they still have that, or 6 months later, do they still have that macro in there? Why did they get that? Why is there an immunoglobulin binding to troponin and causing those elevations and so forth? So what's the mechanism behind that? Is there pathophysiological reasons? So there's a lot of, and then what's the long-term outcome? Well, is there significance to any of these? In the short term, it may be very important to say that, yeah, you're not having an acute event, but in the long term, is it something that needs to be followed up? So there's a lot of things we don't know about macros, but at the end of the day, it is an area that seems to be obviously something that seems to cause discrepancies between assays, which we alluded to a couple of years ago, but has been nicely demonstrated in the clinical chemistry publication by Lamb and colleagues in the March issue of this year, that really says that these macros could be the main reason why we see discrepancies between the assays. And so it's something that we need a lot more work to try to understand, that's for sure.
Thank you very much for your insights, Dr. Kabsak. This now concludes our question and answer session. I would like to once again thank Dr. Peter Kabsak for providing his excellent presentation. And thanks to all of you in the audience for watching this AACC webinar supported by Beckman Coulter China. If you have any questions following this program, please email our customer service at cusserv@aacc.org. Again, that's custserv@aacc.org. Thank you very much and have a wonderful rest of the day.